Hello, and welcome to Hopkins at Home. Thank you for joining us. I'm Elizabeth Marsh, a doctor at Johns Hopkins Hospital, and I'm a stroke neurologist whose research is in stroke recovery and improving outcomes for stroke survivors. I'm an associate professor, and I am the director of the Bayview Comprehensive Stroke Center right here in Baltimore. Today we'll be talking a little bit about sex differences associated with stroke, differences in the cause, in treatment, and how we consider recovery. You're welcome to ask any questions by using the chat box on your screen throughout the talk, and I'll hopefully be able to leave some time at the end to also address some questions. So I look forward to having a good dialogue. You can find out more about my work at www.marshlab.org, and I'll show you a little bit about that at the end as well. So let's get started. Just as far as disclosures, again, my work is in stroke recovery, and I use functional imaging, or MEG, to investigate post-stroke cognition, and am supported by both the American Heart Association and the NIH, as well as by grateful patients. So today I want to talk a little bit about sex differences from multiple aspects of stroke. I want to talk about the global impact of stroke, and then talk about etiologies, management and prevention, and recovery standpoints. So I don't think I have to convince any of you all that stroke is common and disabling. It occurs nearly 800,000 times annually in the United States, and is actually the leading cause of long-term morbidity. We've fortunately dropped to the 5th leading cause of death, but still very, very common. And it actually results in over $36.5 billion in healthcare expenditures and lost wages, and people not being able to go back to work and returning to their lifestyles, which is a major issue. And why is it so common? Well, it's because the risk factors are common, right? Hypertension, diabetes, atrial fibrillation, or irregular heart rhythms. And as the population gets older, and we live in America where our lifestyles may not be quite perfect, people accumulate more and more of these risk factors, and their risk for stroke increases. I want to start by talking about some common myths. So first of all, stroke isn't more common in men, actually. Greater than 50% of strokes occur in women. There are 3.8 million women versus 3 million men, so big numbers in both groups, living with stroke. And this is similar between women and men for both ischemic strokes, where you have a blood clot that blocks a blood vessel, and hemorrhagic strokes, where there's bleeding in the brain. So similar rates between groups for both of those types. Interestingly, women tend to be older when they have their strokes. They do live longer than men on average, so this may not be surprising. And they're more likely to die of stroke. So it's the 3rd leading cause of death in women. But they don't die in the hospital. They often die of their strokes at home once that they've been discharged. So that comes to some of the recovery issues that we'll talk about later in the talk. I want to first talk a little bit about treatment in stroke. I wouldn't be a good stroke neurologist if I didn't do that. So before 1995, a lot of stroke was focused on recovery because we didn't have a lot of great treatments. In 1995, the first treatment was FDA approved. It was called tissue plasminogen activator, or TPA for short. It's kind of like Drano for a sink. When you have a clogged pipe and you pour in the Drano, it helps the clot to dissolve. That's what TPA does for blood clots. And we've been using TPA for the first couple of hours after stroke to help dissolve blood clots and open that vessel back up since 1995. For about 20 years, that was the cutting edge technology for stroke. And then based on the cardiology literature, actually, we figured out that we could do a little bit better. And that's by actually going in the same way they do when someone's having a heart attack. You go straight up through the leg and you put a catheter all the way up, but go past the heart. You don't stop there to take the clot out, and you go right into the brain. And you can actually extract the clot manually. We give patients TPA, and then we do this procedure. And what we found is that we've been able to improve outcomes significantly. It's really exciting. So this is what we call a modified Rankin score, or a debility score. So if you have a score of 0 when we're all done, that means you have no symptoms. We succeeded. You're perfect. You're back to normal. 6 is death, not ideal. And what you see is that people that were treated with TPA and the mechanical thrombectomy tended to do better, to have more of these scores down here as opposed to the control group. Exciting. We're really making progress. So what does this mean for women? How are the differences between men and women? Well, the problem with TPA is that we know that if you don't arrive to the hospital within the first couple of hours after your stroke, you're not a candidate. And that's because as time goes on and you infarct or kill more of your brain, when we give this medicine, your risk of bleeding is higher. And we don't want that to happen. So the problem that we find often is that women tend to come later on. They stay home because they're not sure if they're actually having a stroke, or they wait, almost hoping it will go away. So they tend to arrive later and are not as often candidates. A lot of women know about TPA when we ask them, but weren't aware that there was a time issue. So it's a great place to educate and to let people know that as soon as symptoms begin, whether you're a man or a woman, you need to get to the hospital, because there are treatments we can give you that really improve your long-term survival and quality of life. Women also present with atypical symptoms. So I think we talk a lot about how if all of a sudden an arm or a leg doesn't work, or you can't see, you can't speak, or you can't walk, and it happens right acutely, acute onset, you need to go to the hospital. But sometimes women can have funny symptoms like hiccups or other things that turn out to be a stroke, where they present differently, and this can be confusing. What I want to advocate to everybody is that if you have the acute onset of symptoms and you just aren't feeling well, you should go in and be checked out to make sure that there's nothing more serious going on. Someone had already asked in the chat a little bit about TIA, or a transient ischemic attack. That's where you have symptoms and then they go away. People often think that that's not a big deal. Oh, if they went away, then I must be fine. But I want to caution you there that that's actually a really big deal, right? If you have chest pain and then it goes away, you don't worry any less about having a heart attack, right? You go in because you don't want to have the heart attack. And that's the same thing with TIA. It's a warning sign. You have those symptoms because there's a problem with a blood vessel, and you need to go in and have it checked out, because it's the perfect opportunity to prevent a big stroke. I want to move a little bit into the different causes of stroke and the differences between men and women. Let's start with the common risk factors. So we do know that before menopause, men do have higher rates of stroke due to our regular risk factors, right? Being overweight, high cholesterol, high blood pressure, diabetes. But that once women hit menopause, that actually, the scales tip, and they don't just equalize out, they shift in the other direction. So as far as blood pressure goes, postmenopausal women are at high risk for high blood pressure and then going on to get a stroke. And that's often because, well, they're more likely to go to the doctor and be on medication. For whatever reason, they're less likely to actually have their blood pressures under good control. So it's something we want to make sure that we're monitoring at home to make sure not only that we're on treatment, but that the treatment's working and is effective. There's higher rates of obesity in women after menopause. There's high cholesterol. And then atrial fibrillation is a big one, not necessarily associated with menopause, but with aging. And like I said, women tend to live longer than men. So there's a lot of women out there with AFib, because AFib tends to be a disease of older people. Atrial fibrillation by itself is manageable and treatable, but we want to treat people with blood thinners to help prevent clots from forming in the heart. And women are less likely to be placed on a blood thinner, or at least they were before the new blood thinners have come out. I'm very interested to see the new research and the sex differences related to treatment to see if that's made a difference. So we'll be watching out for that. But it is important, and if I can stress anything, it's to make sure that you're taking care of yourselves and that you're getting your risk factors under control and keeping an eye on them, because that's the best way to help prevent a stroke from happening. Aside from traditional risk factors, there's some sex-specific etiologies, some other stroke causes that are more likely to affect women, younger women, that we should talk about. The first is sinus venous thrombosis. So what does that mean? So most of the strokes that we talk about are due to the arterial blood vessels, the arteries that come from the heart that feed the brain getting a clot in them. A sinus venous thrombosis is a clot in a vein, kind of like when somebody has a clot in their leg, right? That you've heard of a deep vein thrombosis or DVT before. Well, the same thing can actually happen in the veins in the brain. So you can see here, this is the venous system, and the arteries bring in the blood and the veins drain it away. So you see here, there's this nice one in the middle. It's huge. That's draining all the blood from the brain, and it comes down here and wraps around. But what's missing on this side? Its partner. It's supposed to look the same on each side. That's because there's a big clot here. The problem is if the arteries bring the blood in and the veins try to bring it away, but there's no way to get the blood out, it's kind of like when a toilet gets backed up and the pressure increases and increases and increases. And this can actually cause damage to this area of the brain that's supposed to be being drained, and stroke or bleeding, which is a big problem. This stroke subtype, sinus venous thrombosis, is the most prominent difference between the sexes. So 70% of sinus venous thromboses are in women. And part of that is attributed to oral contraceptive use and to pregnancy. So far more likely to be a younger woman's disease. Not that it can't happen in men. I have plenty of male patients that have either been dehydrated, or cancer is a big risk for this, things that make your blood clot more, but absolutely more common in women, particularly women with an underlying clotting predisposition that they probably didn't know about. Some factor that hasn't made them have other clots, but in the setting of these other risks is just enough to kind of tip them over the edge and cause a blood clot to form. Another cause of stroke in women more than men, especially in the younger populations, is hypercoagability, or thick blood. The blood's increased propensity to clot more than normal people. Clotting is important, right? If you cut yourself, you want the blood to clot. So in some ways it's normal, but not when it clots too much. Pregnancy itself is a hypercoagable state. And again, that's because when you're giving birth, you don't want to be hemorrhaging everywhere. You want the blood to stop. The problem is, because of that, it's also a hypercoagability state during the last trimester and postpartum that can actually increase stroke risk during that period. That's probably because of venous stasis, right? So women are often less active when they're pregnant, or when they're very, very pregnant. And because, again, a group of people have mild issues with their coagulability that never would have come to fruition except and caused a problem, except when you add another stressor like pregnancy to it. Other ways pregnancy can cause increased stroke risk in women is by things like pregnancy-induced hypertension or preeclampsia, or pregnancy-induced gestational diabetes. And the problem with these two issues is that will increase your stroke risk later in life. And when somebody has pregnancy-induced hypertension or diabetes, they want to make sure that they're actively controlling their risk factors as they continue to get older. So it's a good warning sign that you want to make sure that you're aggressive about controlling risk factors, so that as you age, that doesn't end up putting you at higher risk for stroke. The other time I think about hypercoagulability, particularly in women, and the risk of stroke is with autoimmune disease. So things like lupus, right? That does tend to be more common in women. And that can generate antibodies. So the problem with lupus is that your body makes antibodies, which is good, right? It helps you fight infection. We're looking to do that for COVID. But when the body generates antibodies against itself, like it does in lupus and other autoimmune diseases, that's a problem. And some of these antibodies can make your blood thicker and result in strokes. And that's what lupus can do. And if you had these antibodies, then you need to be on a blood thinner to help decrease your risk. And again, that's something that affects women more commonly than men. Another syndrome that commonly affects women more than men is something called Reversible Cerebral Vasoconstriction Syndrome, or RCVS. Please call it RCVS. The rest is a mouthful. And this is a thunderclap headache. So not just a typical headache, but a thunderclap headache, almost the worst headache of your life. What happens, or what we believe happens here, is that the vessels spasm. And that can result in either bleeds or strokes in people where this has happened. Why are women more susceptible? I'm saying it's anywhere from 2 to 10 times more than their male counterparts. And look, the age is relatively young. Well, they're probably more susceptible for several reasons. But one of the things that we're beginning to understand about RCVS is it's about the reactivity of the blood vessels. And there's something about RCVS that's similar to migraine in the vasoreactivity, or at least we think that that's part of the key. And more women have migraine, so their blood vessels have more of this vasoreactivity and might put them at higher risk. That doesn't mean that every bad headache you have is RCVS, but it does mean that if you have a thunderclap headache, especially if there's symptoms like weakness, difficulty speaking, or other neurologic signs associated, you need to be seeking help to make sure that you're not having or at risk for having a stroke. Why are women more susceptible? Well, again, they're more likely to have migraine. So migraine is associated with RCVS, and also some of the medications that women take. So SSRIs, or the antidepressants, are commonly, again, they don't cause RCVS, but in somebody who, for whatever reason, is susceptible, that can be a trigger. And more women tend to be on SSRIs than men. So it's something that we think about. Pregnancy can also be a trigger, and we've already talked a little bit about other issues with that. The last cause that I want to talk about being a little bit different in women than men is migraine with aura. So migraine tends to be highly prevalent. 1 in 5 people suffer from migraine, myself included. Good people have migraine. And migraine with aura is pretty common too. So you get the little stars in your vision, or sometimes people even have word finding difficulties or heaviness of their arm and leg, kind of similar to a stroke. Again, this happens much more commonly in women, 4 times more likely. And we've had numerous big studies or meta-analyses that have shown that individuals with migraine, or specifically migraine with aura that has these associated symptoms, are at higher risk for having a stroke long term. Now, we're going to talk in a minute about how we think about that and why we shouldn't panic. But I will say and use this opportunity right here to talk about the fact that it's always associated with other risk factors, right? So smoking triples that risk, and using oral contraceptives, right? Another potentially hypercoagulable trigger will take a risk and will magnify it. So thinking about your overall health is really important, especially when you have one of these smaller risk factors that we've discussed or will be discussing. So from the Women's Health Study, this big study that was done, migraine with aura actually accounted for 4 additional ischemic strokes a year in 10,000 patients. So it doesn't happen a lot, but it does happen and cause, it's an extra cause of stroke in women, and relatively young women, right? And this is important because when we think about female deaths a year and we compare stroke to breast cancer, twice as many women are dying from stroke a year as breast cancer. And not that that makes stroke any bigger deal than breast cancer, but it's just to highlight that stroke in women is a big problem, a big public health problem. And we want to be sure we're educating and we're thinking about mitigating risk factors and prevention, as well as treatment and management in women and men. I want to move a little bit and talk about some of the other differences we see in treatment of stroke, as well as in thinking about prevention or other risk factors for stroke in women, and use some examples to show you how we think about kind of when I sit down with someone, whether they're a man or a woman, I consider their sex when I'm thinking about the different treatment options that I'm offering or some of the prevention strategies. So let's look at carotid disease. So we talked a little bit about how atrial fibrillation or an irregular heartbeat can cause a stroke. But another big cause of stroke, especially in the United States, is carotid disease. So the heart's here, and it sends 2 blood vessels up the front and 2 blood vessels up the back. The 2 up the front are called the carotid arteries. And they're a great place to have plaque form. And plaque is caused by high blood pressure and high cholesterol and smoking and that steak that we like to eat all the time. Those traditional risk factors cause this plaque to form in the vessels. We know that if you've had a stroke from this plaque, that the best thing we can do is take it out. And the study that showed this was a big study published in the New England Journal of Medicine in 1991. And they repeated this in Europe. So there's pretty good data that this is the thing to do. However, interestingly, what they noted was that women had less benefit over the long term to doing this surgery and for stroke prevention than men did. And that's probably because women have smaller vessels, so it's harder to get up and access those vessels. And it may also have to do with how they respond to medical management. But it's a really good example of how, even though this is effective in women, I think about it differently than I do in men about who I send to surgery and the considerations I have with that. Another big topic in thinking about stroke risk and in about both before and after stroke is our oral contraceptives or hormones and how they're related to cerebrovascular disease or disease of the brain blood vessels. Since the 1960s, there have really been 4 big meta-analyses that have grouped patient data together to look at what the effect is of oral contraceptives, because it's a big issue. There's a lot of women taking oral contraceptive pills. In the 1960s, they are published in the 1990s, I guess, they showed nearly a 3-fold increase with stroke using any oral contraceptive pill. Another study showed a 2-fold increase. So fairly consistent that maybe people were having more strokes when they were on oral contraceptives. And it's important to point out that this is the estrogen pill, the progesterone only pill, which is more difficult to take. And I know a lot of people aren't as big a fan for lots of different reasons. There was no increased risk. So we're really talking about the estrogen. In the women's lifestyle and health cohort study, which was nearly 50,000 Swedish women that were followed from 1991 to 2004, interestingly, they didn't find any association with OCP use. So what's different? What gives? Well, some of it probably has to do with dosing. So there's a nice study in Denmark that looked at 1.6 million women, and look at the ages are relatively young. And what they found was that the risk of ischemic stroke was very much based on the dose of the estrogen that they gave. So higher doses, which is what we used to give with the estrogen pills, did result in a 2-fold increase in stroke. But the 20 microgram pills, this risk was significantly decreased. Again, the progestin only had no increase. And then using things like the transdermal patch or had also much lower. More recently, they've looked at the IUDs and at the Mirena, and those also have a much lower risk because they're acting on the local rather than the systemic level. And this is important, right? Because one of the things that I consider as a neurologist and as a doctor in treating patients is I don't want to tell someone that they can never be on an oral contraceptive pill. But if they have migraine with aura and other risk factors and want to be on oral contraceptives, all of those things are slowly increasing their risk. How am I going to mitigate that? Well, one of the absolute things I'm going to do is think about the dose of pill that they're on. They have some really terrific low dose pills these days, or maybe an IUD would be a better choice in this kind of individual. So these are factors that we're thinking about as we're counseling patients, but we're taking into account the fact that telling someone that they can't be on any oral contraceptives often is not, whether it's because of PMS symptoms or the desire to prevent pregnancy, is not an option. And we want to make sure that we're doing what's right for the patient in front of us. Based on this data, for every 10,000 women on low dose contraception a year, 2 will have an ischemic stroke, and 7 more will have that sinus venous thrombosis that we talked about. So again, it's not without any risk, but on the lower pills, the lower dose estrogens, it's much lower. Thinking a little bit about hormone replacement therapy, not the oral contraceptives, but later in life, right after in perimenopausal and menopausal women, initially some early observational evidence suggested that maybe there was a benefit to being on hormones and helping to prevent cerebrovascular disease. Wouldn't that have been nice to be the case? Because it certainly relieves some other symptoms. However, unfortunately, 2 randomized trials have since been negative, and that was both this heart and estrogen progesterone replacement study, or also known as HERS, as well as the women's estrogen for stroke trial, or WEST. There have been additional studies that have shown potential increased risk, actually, including the Women's Health Initiative that actually showed an increase risk for stroke on patients that were on estrogen. So again, I want to make sure that I emphasize here that as we get information and as we're thinking about all of these risk factors and how they're different for women than for men, all of these things are just information, and each risk factor is kind of a building block where eventually you hit the threshold where your risk for stroke is high. So my goal as a provider is to take all of your building blocks and figure out how I can make them as absolute low as possible. And what does that mean? Well, if you need to be on hormone replacement therapy, making sure that you're on the lowest dose possible. If you have migraine with aura, right, keeping it under control, making sure that you don't smoke, considering whether maybe you shouldn't be on OCPs if at the same time. Maybe putting someone that does have higher risk and does need to be on OCPs with migraine with aura on a baby aspirin. And there's really good data, or at least good data, that suggests that keeping migraine frequency under control is a great way to control that building block, so that individuals that have less than a headache a month have a lower rate of having ischemic stroke down the road than individuals who have monthly or weekly headaches. So these are all things that we take into account. I wish I could make them all go entirely away, but what I'm trying to do is to decrease them as low as possible. I want to move, and let's see. I'm just going to check the chat for just a second, and before I talk a little bit about recovery. Oh, that's great. So I was asked a little bit about what other odd symptoms women get other than hiccups. That's a great question. Oftentimes, women will feel anxiety. So they'll, when they first experience stroke symptoms, they'll feel the sense of doom. I've heard that one. I've heard hiccups. I've heard fatigue. And then the traditional risk factors that they just say, oh, I thought it was nothing, or I wanted it to be nothing. Great. Okay. I want to move for just a second and talk a little bit about stroke recovery, which is also different, similar to the etiologies and the treatments for stroke, and really where my passion and my heart is. So consistently, studies have shown that, unfortunately, and for probably many different reasons, women have less favorable outcomes after they have a stroke. Some of this is probably due to the fact that because they are older, they're more likely to be widowed and living alone prior. But they're also found to be less likely to achieve their independence after their strokes, and less likely to be discharged home. And some of this, which we'll talk about in a minute, is really tied into the difficulties with mood and fatigue that can impact stroke recovery, and how women often are more affected by these. In looking specifically at clinical outcomes, several studies have reported poorer 3 and 6 month functional outcomes. And this is even controlling for age and depression. And other studies have reported that with respect to language as well as to motor recovery, there are differences between men and women that we just don't understand yet. Why a woman with aphasia, or the inability to speak, will recover differently than a man with similar symptoms. This is something that people are working on in the recovery literature every day to try to better understand and figure out whether our rehabilitation paradigms need to shift to make it more effective for both groups. In this study, they found, again, similar to what we had been talking about before, that the women stroke patients were older and more likely to have other comorbidities, probably in part because they're older and had accumulated more risk factors, but that, like we've been talking about, they were less likely to achieve independence and had significant problems with their thinking and energy, which I hope I can reinforce to everyone by the end of this talk. That's a big problem. So I want to talk about our patient population, because I think that brings it home and is particularly relevant in what we found in kind of looking at differences between men and women. So over a 14-month period, we had about 100 patients who came back to clinic and filled out a lot of information for us to allow us to learn about stroke recovery and how different patients were impacted. They were administered this memory and behavior scale that asked them about the things that they were having trouble with and were doing well. You can see that in general, our patients that returned and filled this out for us had relatively minor strokes. And what I mean by that is their NIH stroke scale scores, their severity of their strokes were low. So for the NIH stroke scale, you get points for everything you can't do. If I can't hold my arms up, I get a lot of points. If I can't speak, I get points. If I can't feel, I get points. So only having about 4 points when they come back is pretty good. It means overall they're recovering pretty well, as opposed to a massive stroke where they can't move their arm or their leg, they can't see, they can't speak. Their NIH stroke scale would be something like a 15 or a 20. So a little bit different population here. That was about 65 to 70 years old, and about half of them were women. Now, it's interesting, we're going to talk a lot about fatigue and depression, but about 20% had a prior history of depression in our cohort, but nearly half of them were on an antidepressant when I saw them. So take this with kind of that grain of salt. What we found is that within this group, and this was true for men and women, but particularly for women, they reported a lot of problems with their functional independence, as well as depression and fatigue. And there was a sex predominance with women with respect to fatigue that we're learning more about and learning how to manage. So let's take an example and see how this plays out with Mrs. K. And so Mrs. K was a 70-year-old lady who had high blood pressure and high cholesterol. And she came in to see me and had this small little stroke. So this is a copy of her brain. It's like she's lying on her back. So her nose and her eyes are up here, and the back of her head's here. And you see that white area right there? That's her stroke. So it's on the left side of her brain, which controls the right side of her body. And this is in just the right location that, even though it looks rather small, when she first came in, she couldn't move her arm or her leg. So she couldn't walk. She couldn't get out of bed. When I discharged her, she went to rehab and she got stronger. And 6 weeks later, she was back to most of her activities. So because it was so small, it was able to recover well. And she was able to get back use of her arm and leg, although she still couldn't do this very well. The hand, unfortunately, takes a lot to recover because it's so complex. So she was having a lot of trouble using a knife and fork or writing. But what she was really complaining about through all this was these other symptoms that were really bothersome to her because she didn't understand them. Her short-term memory was terrible. She couldn't remember anything her husband told her. She was also really apathetic. That was more his complaint than hers. But she was having trouble paying attention. When they go out to dinner, they like to do that with couples. She had trouble following conversations from multiple people. And it was really hard for her to take in a lot of information. She'd get very, very overwhelmed. And this was what was really bothering her. She was so thrilled she'd come along physically so nicely. So why am I telling you about this? You said she's recovered well physically. She should be happy. Why does this matter? Why are you focusing so much? Well, I'll tell you, this is really becoming the norm or a norm of what we're seeing in stroke recovery. Because remember, I told you, therapies have advanced so much. Before we did thrombectomy and TPA, people's strokes looked huge. They did have hemiparesis and the inability to move or to speak for a long time. Now we're making those strokes so much smaller, which is terrific. But now we're seeing this group of other problems that are really debilitating and lead to terrible quality of lives that we have to figure out what to do about, and how men versus women are affected and how we want to tailor treatment. One of the things that she complained about most was fatigue. She was exhausted. I had no idea that, I'd try to do something, make a sandwich, and I'd be exhausted. What's going on? I used to make sandwiches all the time. The way we measure fatigue is on a scale called the FACIT, where you get points for how much energy you have. So it's on a scale of 0 to 52. Where 52 is, I have all the energy in the world. I would love to be that person. A score of 30 or less is severe fatigue. Cancer patients have 30 or less. In our population, a third of people were reporting a month out of their stroke, 30 or less. And a lot of them were women. So what we wanted to do was look at that and say, what are these predictors of fatigue early and late? Because a lot of people would then improve, but some wouldn't. And what we found is that sex had a lot to do with it. So especially later on, so if we're looking at initially, so in the month after stroke versus later on, 6 to 12 months after stroke, women were much more likely to have fatigue late and to have persistent fatigue that significantly impacted their abilities to function and to go back to their activities. Early on, we found stroke had a lot to do with it. How bad their deficits were. Remember that NIH stroke scale, as well as where it was. So strokes in the back of the brain were important and were more likely to make you tired. But later on, it was risk factors and other medical problems like blood pressure, like having obstructive sleep apnea, and using medicines that could make you tired. But notice this, very important, depression and anxiety, mood problems made you fatigued all the time. And women are particularly susceptible to those. Post-stroke depression is really important too, and it goes hand in hand with fatigue. The way we measure this is by something called the PHQ-9. And that's, you get points for, again, where you want to be you get points for depressive symptoms, how depressed you are. So higher scores are bad. So I have little interest in things, gets you more points. I feel bad about myself, gets me more points. A score of 5 to 9 is mild depression. Our patients on average were scoring a 5.6 when they come back to see us. So they were all mildly, or more than half were mildly depressed. And remember how I told you a lot of them were already on antidepressants, so still feeling that way. Can I convince you that when you're trying to rehab, when you're depressed and don't really have the desire to get up and move or to work with your physical therapist, that can be a big problem after stroke, something we absolutely want to make sure we're addressing. And unfortunately, we know from lots of literature that women are more than twice likely to suffer from post-stroke depression than their male counterparts. One of the things that's really important to me, like I was alluding to at the beginning of this talk, is post-stroke cognition. So their ability to think after a stroke, to be clear, to do that multitasking, right? We all want to be able to take in information and process it quickly and to do all the things that we enjoy doing. This is what we call the MoCA. Some of you that I've seen in clinic know this pretty well. And this tests multiple aspects of our cognition, of how our brain works. So we do things like having you connect numbers to letters. So 1A, 2B, that focuses and exercises the brain. We have you draw three-dimensional objects, name funny looking animals, keep lists of words in your mind and say them back to us for memory. And this tells us kind of how each of those modalities is doing and how the stroke has impacted that. You can see, looking at this bar graph, that patients that have no stroke, so this lightest color, do better in every single domain, not surprising, than patients that have strokes, and that patients with major stroke do the worst. But look at patients even with minor stroke, with these small strokes that we're talking about, have fairly significant cognitive difficulties, this ability to do these things compared to the people without strokes, which is very debilitating and very frustrating to them. And what we found as far as predictors, fortunately, we didn't find a sex difference. Fortunately or unfortunately, I don't know, but that didn't seem to be geared toward men versus women. But what it very much was geared toward was their baseline. So if they were high functioning at baseline and were independent and were using their brain to think and were working or were active and involved, they were far less likely to have as big a dip. That doesn't mean they didn't have any dip, but as big a dip in their cognition. And then their brain baseline. So this CHS score is how much white matter disease you have, how much brain disease, how much ischemic damage you've already had in your brain from things like blood pressure and smoking. And people with lower scores did better and didn't have as much of a drop in their cognition. So baseline is really important. And even though it's boring and not very sexy to talk about keeping your brain healthy and doing those things and behaving when you're in your 30s and 40s and 50s, that's what, when you have strokes later on, helps you to recover even better, regardless of whether you're a man or a woman. But let's talk a little bit about those differences. So that MoCA that we talked about, that screen, how did people do over time? So at their first visit, I told you, if a 30 is completely perfect, you don't have to be perfect. Most people with normal cognition are somewhere up here in the 28, 29, 30 range. So our post-stroke patients at 1 month on average were right around here in the 25s. When I'd see them again at 6 months, they'd had a lot of family involvement and a lot of therapy, rehabilitation, and their scores were much improved, or at least somewhat improved. They were closer to this normal range. But look at what happens at 12 months. I'm going to show you a little bit more, but there's a split. A group of patients continue to stay stable and improve, but a group decreases again. And let's look at that group. On that MoCA, that's what the women are doing. So they go up, and then at 12 months, their average is starting to come back down. Versus the men that I was seeing in clinic, where they continued on that positive trajectory. And this wasn't just true for the MoCA, it was true for other cognitive testing that we were doing as well. So see, women are having this pattern where they peak at 6 months and then start to go down, whereas the men are continuing to climb and improve. And for this as well. Why? What's going on? Well, we have a couple clues. And that's really one of the things that we're working on the most, but I want to highlight. One of the things that we noticed was when we asked people in collecting information about their satisfaction with their recovery, women were quite satisfied with how they were doing and with the situation they were in. And men had this dip at 6 months. So we started to probe that a little bit more. And you know what we found? We found that at the 6 month time point, they were sick and tired of their families nagging them all the time for needing to continue to do all their work. And it was interesting because those same men would come back at 12 months and say, oh, you know what? My daughter or my son or my daughter-in-law, she was right. And I'm doing so much better now. So I'm not sure if it has something to do with the family involvement, but it's interesting, and it's something we're continuing to probe as far as how family structure and how family input is making a difference in recovery and how it affects men and women differently. Otherwise, we didn't find major differences between the two groups, which is important, right? Because if they're recovering differently, what is it that we're missing? And their numbers, if I can just put this up here to illustrate, there's not major differences in their risk factors or in any of their other data. So one of the other things that we've been looking at is there a difference overall in their brains and how their brains reorganize? And one of the ways that we've been doing this is by using this functional imaging. It's called MEG. It's almost a cross between MRI and EEG. So you go in, you put these nice little stickies on your head, right, like this, and you go into the scanner and you do a task. And while you're doing the task, the scanner looks at your brain activity. And it looks at your brain activity and we're learning some interesting things. So one of the tasks that the subjects have to do in the scanner is they have to match. They have to match words and pictures. And this is the control group without strokes. And this is the brain activity. And you see this nice, large amplitude brain activity with these peaks here. This is our stroke patients. And you see how it's much lower amplitude. And the peaks are kind of washed out. Now, I'll tell you, interestingly, so far, men and women look the same. So there doesn't seem to be a difference here, but the strokes look far different than the controls, especially at that early on time point. And now we're following them longer and longer, and we're starting to see them look more and more like the controls over time, particularly people who recover better. And we're still trying to figure out what it is that makes someone recover better. And hopefully, ultimately, if there's someone that we can either intervene with a therapy that will make them look more like this, or if we can even tell based on their initial imaging which group they're going to fall into and what they may benefit most from. One of the other things that we found with MEG, with our functional imaging, is we could see where activity was most prominent. And what we found, remember how I told you that fatigue and depression are very, very common after strokes. What areas that lit up were the frontal lobe that's responsible for that. So perhaps people with more frontal lobe activity, it's a good sign that they have significant issues and might benefit from some more treatment, pharmacotherapy, counseling, other things like that to really improve. How does this impact treatment? Well, what we've learned so far tells us we have to be very aggressive, men or women, about treating post-stroke depression. But given that it's more common in women, particularly in women, using things like therapy, like medications, and more recently, we've been doing some work with mindfulness and seeing how that impacts post-stroke anxiety and depression. Addressing those medical comorbidities. Remember, along with being a woman and the anxiety and depression, having a lot of medical comorbidities can increase your fatigue for the long term, which makes it much harder to recover. Encouraging families, right? Getting them to push so that after 6 months, when rehab therapy runs out, there's still people pushing you so that you continue to use your brain. The brain is like anything else. It's use it or lose it. And then to be determined. So we're still awaiting more studies on different hormones, functional imaging, that can different strategies for behavior that can ultimately improve cognition, fatigue, motor, and language symptoms. So in summary, before I open it up to questions, and I see a bunch in the chat already, stroke is really common, but remember that it can present differently in women. Whether you're a woman or a man, the acute onset of symptoms, it's so important. Come right to the hospital for an evaluation. There's treatments that can be really beneficial, but they have to be done early. And if your symptoms come and go and you have a TIA, come to the hospital anyway, or at least call your provider, because that's something that needs to be worked up right away to prevent another stroke or a stroke that stays and that lasts. While vascular risk factors are important in women, particularly after menopause, there are some sex-specific etiologies. So remember that those things that can put women more at risk in their early years: the sinus venous thrombosis, being hypercoagular or having thick blood, autoimmune diseases, and migraine with aura. And then in thinking about once you've had a stroke or preventing a stroke, things that are tailored to you as a woman, or specifically in how you think about hormone replacement and migraine and carotid disease. Those are all important factors and really should be patient specific and in light of the rest of the risk factors that you're having. Recovery in women has to focus on really the appropriate social support, and particularly focusing on post-stroke depression and fatigue. It makes a huge difference. Not always easy, but something that's really important. Women have higher rates of baseline depression, and because they're older, they often have a lot more comorbidities and less social support right at home, less infrastructure. And then cognitively, again, when there's a lot of support at 6 months, people are often better. But the big range and the big area for potential decrease in function is really that 6 to 12 month period, where often there's less resources available, and that's a prime time for people to backslide a little bit, and something we really have to watch. I want to make sure that I say thank you before I take questions to all of the people that work with me, both in the clinical setting, my stroke team at Bayview, who works on the inpatient setting, as well as seeing everybody outpatient, as well as my research collaborators, both within my lab. All my undergraduates, the Grays, are people that have moved on and are now clinician scientists elsewhere and doing great. And my current lab, as well as my collaborators at NYU and at the University of Maryland, who have really allowed us to make significant advancements in determining recovery and how we should apply it to the sexes, but in stroke survival overall. And with that, I think I'll move the chat to where I can see it and take some of your questions. Okay, let's see. I have a question here about heart studies. Are they done equally in men and women? That's a great question. There is a big push nationally to make sure that we include women within all of our studies, because they do make up such an important part of the population. So currently our studies are fairly well balanced. It is hard to do studies in pregnant women, as an example. That's not something that's been easy to do. So a lot of the past work that have looked at women in pregnancy and some of those issues tend to be more observational studies, because it's much harder to design a study to safely enroll that group. But in general, when we're looking at large groups of people, we make a point now to make sure that we, both from a gender perspective as well as from a racial and ethnic perspective, are including a variety of people so that we can really generalize them to our populations. That's a great question. There's a question here about differences for monitoring during anesthesia. So you're right, Beth, that peri-op stroke risk is important. So strokes, part of the reason that strokes occur during procedures is because of that relative hypercoagulability that we talked about, right? When you're being cut for a procedure, the body doesn't like that. It doesn't want you to bleed. So it tends to kind of have a transient hypercoagulable state, which can put you at risk, and other things like arrhythmias. So when your body gets under stress, you may be more prone to having an irregular heart rate. What I think about and worry about with anesthesia specifically are really two things. One is blood pressure drops. So if you have a stenosis, a tight vessel somewhere, and you drop pressure too much, that can cause a stroke. So what we tend to do is often you'll see that when you're thinking about undergoing a procedure, you'll be evaluated by your primary care doctor, who will think about your risk from a heart perspective and from a brain perspective. And sometimes they'll even recommend that you get an ultrasound of your neck to look and see if you have some stenoses in the right person with a lot of risk factors. So that's one reason why, because we think about blood pressure drops. Anesthesia has gotten really good at not dropping blood pressure during procedures, being mindful of that. So that's another way to mitigate that. Additionally, people that have had strokes, when they undergo anesthesia, stroke symptoms can transiently come back. And that's because when you have a scar in the brain, old damage, and then you put the brain to sleep, when you're first waking up, some of those symptoms, it can take that scar a little bit longer to kind of wake up also. So if you had a stroke and had gotten really weak in your arm and leg, sometimes undergoing general anesthesia, you'll wake up a little weak on that side too. It should rapidly resolve, but it's scary, right, for families or for the rest of the medical team. So it's things we think about, but there aren't specific sex differences there. I worry about that for everybody. Great question. There's a question, do you encounter the condition known as anosognosia or lack of insight in stroke patients? Yes, so that's a great question. So anosognosia is a condition where you have problems and you don't have insight into the fact you have problems. It tends to be due to strokes in the right hemisphere. So strokes in the right hemisphere for both sexes are really hard, because when you have a stroke in the left hemisphere, usually people have language problems, and everyone around them knows they've had a stroke in the left hemisphere because they have language problems. Right hemisphere strokes don't have language problems. Instead, those same areas are responsible for kind of making us who we are and how we interact. And anosognosia, that insight, is part of that. So when you have a stroke, you're talking somewhat normally, you seem normal, but you're kind of weird. Why are you weird? But you seem normal. So they have problems integrating and problems interacting, and often will kind of clash with their families or with rehab, but it's less clear why, because they seem okay. So that can be a big problem. And that insight, that lack of insight into, oh, I don't have any problems, what are you talking about, is a big problem with rehab, right? And sometimes that can even be when people are weak. I'm not moving this side at all, I'm fine. And that is a right hemisphere issue that we see not infrequently and can make it very, very hard. It's important to acknowledge it, and it's important to acknowledge it not only for patients, but for family members and for rehab. And then there are strategies to work around it, but it can be very difficult, you're right, because it doesn't show the same way the left hemisphere strokes with big language problems do. Let's see. Are there differences in what constitutes an ideal neuroprotective diet for men versus women? That's a great question too. So not really. So I wish we had the optimal neuroprotective diet. In general, the studies have shown that the Mediterranean diet is closest to being ideal for risk reduction, but in reality, it's about moderation. So what I tell people is, again, like everything else here, I'm not going to tell you can never have a steak or never have a piece of cake, but how about not for breakfast, lunch, and dinner every single day? So some moderation is good. But the Mediterranean diet is modeling it for both sexes, helps promote good vascular health, decrease plaque, good cardiovascular and cerebrovascular outcomes. So looking at those options and trying to emulate some of that is what I give people as a guide when they ask. Great question. Is lightheadedness and mild dizziness common long range for women after stroke? That's a great question. And it can be. A lot of strokes can cause these vaguer symptoms long term. Often they resolve, but not always. And they can be debilitating, like you're pointing out. I like to refer people to therapy early to learn how to functionally get better. But I even will refer people 3 years out, not to functionally get better. It's not going to go away, but to learn how to cope and to learn how to be functional with that problem that you have. So that's a different question, right? To get rid of it versus to learn how to deal with it and learn how to be functional. That can happen in anybody. It's not just women who feel lightheaded or dizzy, but it can be a very common and somewhat vague that's blown off, but a post-stroke symptom that's really important and can affect people long-term, yes. I have Anne is asking about silent strokes. That's a great question. It's all about kind of the way it's a spectrum. So in the brain, it's all about location. There are areas that don't seem to do anything. Now, remember we talked about how after strokes, there can be fatigue and depression and whatnot. And so I won't say those strokes are silent, but they don't cause your hand to go limp or you not to be able to talk. But there's still areas of ischemia, areas of damage that we can see on MRI. Some of that is what we call that white matter disease. So silent strokes or strokes that don't have a correlate or a readily apparent correlate can add up, and that leads to that baseline that I was talking about. So the goal is that over time, as the brain ages, we keep those kind of silent damage as minimal as possible. But people can, often that's what we talk about when we talk about silent strokes, is a stroke that I can see that there's an area of your brain that has damage. I can see that there's little vessels that have been clogged. Sometimes that can lead to what we call a subcortical vascular dementia, where people will have more and more memory problems. And it's because they have so much of those silent strokes that didn't cause them to have what people consider a major stroke, but will cause them to think not as clearly and to have other issues. But that's often what people are talking about when they say silent strokes and they say they can see them. I like to show people pictures of their brains when they come in, because I think that makes it clearer to see exactly what your brain looks like and what we mean when we say a silent stroke or white matter disease or a lacoon or other things that you have. Otherwise, the mind kind of plays tricks on you and can go a little bit wild and thinking about, well, what does that mean I have up here? Let's see. Are the preventative migraine medicines better than the as-needed ones? Oh, that's a great question. So they work differently, and their goal is to do different things, and they're asking about stroke risk. So an as-needed migraine medicine is terrific when you get a headache. So you get the headache and you take the as-needed medicine and it's supposed to go away, or at least make it better and hopefully go away. That's its job. The preventative medications are supposed to help you take them every day, whether you have a headache or not. And it's supposed to decrease the number of headaches you get. Remember how we talked about frequency is important. People getting daily headaches, it is associated with higher stroke risk. You only need to be on a preventative medicine if you get more than 2 to 3 headaches a week. Otherwise, it's not worth it, right? Why would you take a medicine every day that has potential side effects that you have to remember to take every day to prevent a headache from happening once every 6 months? You don't. that's fine. You take the as needed. Sometimes it's even just Tylenol and Advil, right? Sometimes it's stronger, but you take the as needed medicines when you get occasional headaches. But people who have frequent headaches, we really want to cut that down. And those are the people that go on the preventative medicines. And yes, they've gotten much better, much, much better. There's some great ones out there that are very effective with relatively few side effects. It doesn't mean that they all work for everybody. We have to find the one that works for you, but there's great new medicines out there, and there will continue, people are continuing to make them because it is so prevalent, specifically in women, but in everybody. So it is only continuing to improve, which is great. I'm being told that I only have 2 minutes left and to wrap up. So, I want to thank everybody. It's so much fun to get to talk to you today. I hope I've been able to stress that, stroke is really important and can be devastating. So much goes into prevention, even though it's not the exciting piece. But thinking about your risks, regardless of what sex you are, if you do have a stroke, really tailoring treatment in the recovery process to you and your family, again, regardless of what sex you are, but thinking about some of these issues that are specific to women can be really important. And I'm always happy, please feel free to contact me or to take a look at our website at the work that we're doing. It's a pleasure to take care of you all. Hopefully I won't need to, but I'm always here if there's questions or concerns. And with that, I think I'll say thank you.